Hello, welcome to this webinar. My name is Deb Green and I am the SANE coordinator at Sarah House. Today we're going to be talking about best practices for completing domestic violence exams. Our learning objectives for today will be to identify at least one practice change in the assessment of a patient who has experienced intimate partner violence, and to increase the knowledge in recognizing and responding to visible and non-visible signs of strangulation. So what is intimate partner violence? Intimate partner violence is physical abuse that includes physical assault, battery, and sexual assault used as a part of a systematic pattern of power and control perpetrated by one intimate partner against another. Physical abuse can cause severe injury and even death, and it often co-occurs with other forms of abuse, including psychological abuse, economic abuse, and stalking. Domestic violence is one of the most chronically underreported crimes in the United States. Only 25% of all physical assaults get reported to the police. Only 20% of all rapes get reported, and only 50% of all stalking gets reported to police. And for the number of cases that actually do get reported to police, a woman will be assaulted by her partner or ex-partner 35 times before she reports it. 1 in 4 women and 1 in 10 men experience severe intimate partner physical violence, intimate partner contact sexual violence, and/or intimate partner stalking with impacts such as injury, fearfulness, post-traumatic stress disorder, use of victim services, and contraction of sexually transmitted diseases, etc. Victims of domestic violence can experience a range of behaviors that include slapping, shoving, pushing, and in some cases might not be severe enough to be considered domestic violence. On a typical day, there are more than 20,000 phone calls placed to domestic violence hotlines nationwide. The presence of a gun in a domestic violence situation increases the risk of homicide by 500%. Only 34% of people who are injured by intimate partners receive medical care for their injuries. Children are often victims of domestic violence as well. 1 in 15 children are exposed to intimate partner violence each year, with 90% of those being eyewitnesses. Intimate partner violence in the presence of a child or while a child is present in the home should invoke a referral to Child Protective Services. This is child abuse. So what does an abuser look like? Abusers' main objectives in intimate relationships is to dominate and control their victim. So abusers can be anybody. They're from all kinds of groups, cultures, religions, economic levels, and backgrounds. 90% of abusers don't even have criminal records. They are perfectly law-abiding citizens outside of the home. There is a cyclical pattern to intimate partner violence. The first phase is the tension phase, and this is where the perpetrator increases their control techniques. The victim will feel like they are walking on eggshells. There will be threats and intimidation during this phase and unpredictable behavior on the part of the abuser. The victim will feel fear and guilt during this phase. The second phase is the violence phase. This is when the abuse actually occurs with acute battering. There'll be violent behaviors, and emotional, physical, financial, and/or sexual abuse occurs during this phase. Then the third phase is the honeymoon phase. This is where the perpetrator is remorseful and apologetic, promising to change, bringing gifts, and showering the partner with attention and romantic gestures. They will try to apologize and try to make up for their actions. They often will blame the abusive behaviors on the victim. If only you hadn't done this, I wouldn't have had to hurt you. They often will ignore and deny any abuse has occurred. So how may a survivor present to you? Remember, there is no typical response to trauma in sexual assault or domestic violence. A victim-centered approach includes believing the victim and making no judgment. When we're faced with stressors or trauma, our typical response is one of 3 things: fight, flight, or freeze. The majority of survivors do not fight or flee when they are being sexually assaulted or faced with a domestic violence situation, especially if the perpetrator is someone that they know and trust or thought they could trust. Situations where just moments before were normal social interactions. Most people will engage in reflex and habit behaviors that do not involve fighting or fleeing. If the behavior includes fighting or fleeing, it is usually a reflexive or habit-based behavior. People that have had law enforcement training, military, or martial arts, it becomes second nature for them to automatically try to fight back or try to get out of the way, to flee. Um, but that's not necessarily the case in other situations. Survival reflexes is another type of response, and that is when you freeze. Freezing is the inhibition of movement. It typically lasts a second or two, but it may persist for minutes in some circumstances. Tonic immobility is when the muscles go rigid and the body is paralyzed, and collapsed immobility is when the blood pressure and heart rate drop and the muscles go limp. They may feel faint or pass out. I'm reminded of a situation that I heard of a young girl that was wanting to go to this party because there was a guy that she liked that was going to be at this frat party. And so she talked to her friend, and her friend decided that she would go with her to this party. And they got there that night, and the guy that she really liked was there. And before long, she kind of went up and started talking to him, and they started hanging out by the beer keg, and she was giving her beer and got her a little bit drunk, like had a few drinks, and then he suggested that they go upstairs to a room upstairs. Well, she was all for it because she thought, wow, this guy really likes me. I'm really excited about this. So she went upstairs with him, and they started making out, and she was like in heaven because she thought, wow, this really is what I wanted. This guy really likes me a lot, and she was all for it. And then things kind of took a turn, and he was wanting a little bit more than what she wanted, and he started trying to take advantage of her, and he wanted to have sex, and she said no, and he wouldn't take no for an answer, and so he ended up raping her, and she just froze. She went into this tonic immobility, and she couldn't move, she couldn't speak, she couldn't do anything. And so he gets finished with his business, and he goes out on the hallway, and he finds his friend, and he tells his friend, hey, there's a girl in there and she'll let you do anything that you want to do. So he goes in and he has his way with her, and he rapes her. And he comes out and he goes and finds another friend, and he says, hey, there's a girl up here and she'll let you do anything you want to do. And so he goes up and he rapes her. Before it's all said and done, 5 guys rape this young girl, and she's totally immobile in this tonic immobility. Well, her friend is getting concerned because she hasn't come back. She doesn't know where she's at. And she starts hearing this rumor about there's a girl upstairs that's having sex with all these guys. And she is worried. And so she goes upstairs and she finds her friend laying on this bed. And she's just totally immobile. And she's just totally out of it. And she shakes her and tries to wake her up, and she's calling her name and she's shaking her, and nothing is working. And she finally slaps her a couple of times, and she finally gets her to respond and wake up. And the first thing that she says when she wakes up is, I didn't do anything. I didn't even fight back. Because that's our instinct. We think that that's what we're supposed to do, is to fight back, when in reality, most of us will not do that. Most of us will try to, will freeze. That's our common response. Another very common response is the fawning response. And the fawning response is when you're trying to do whatever it is to please the other person. This is a common thing that I hear also in sexual assault victims, that a lot of times they'll just say, I thought if I just gave in and did what he wanted, he would go away and leave me alone. So the fawning is a very common reaction as well. especially if it's someone that they have known, that they just feel like, man, if I just give in, if I just let it happen, then he'll go away and I won't have to worry about it anymore. But they don't realize how much it's really going to affect them. So, the hippocampus is critical for forming memory, but it's the amygdala's job to file memories. But when danger is present, it stops filing memories in order to sound an alarm. I really like this analogy of the post-it notes. So let's just say that I'm going to take a package of post-it notes and I'm going to write on each of those post-it notes, or about maybe this thick, I don't know. But so I'm going to write on each one of those post-it notes 2 or 3 words, and I'm going to use the whole package of post-it notes, and I'm going to tell you in those 2 or 3 words on each page what I did last weekend. And I'm going to go to your house and I'm going to hide those post-it notes all throughout your house. And I'm going to have you go back into your house and try to find all those post-it notes. How long do you think it would take you to find all of those post-it notes? Probably a long time, right? Well, even more, how long do you think it would not only to find those notes, how long do you think it would take you to find them and put them back in order chronologically? Probably a really, really long time, maybe even never, right? So that's kind of what happens with our brain when we're going through trauma. The brain will try to protect yourself by taking those events and putting it on little post-it notes and hiding it in little cubby holes in your brain because it knows that you can't handle all of that trauma at once. And then it will gradually give you back little pieces of it as it as you're able to handle that trauma. But it may not be in chronological order. And this is why a lot of times when you're talking with victims right after a trauma, they can't tell you in chronological order what happened, and they don't make a lot of sense because their brain is protecting themselves. And this is why you really need to a lot of times wait a couple of days if you can to get a complete history from victims, to give them the time to be able to process this so that they can be more chronological in their history providing. Non-fatal strangulation is very common in intimate partner violence, and it's recognized as the most predictive factor in subsequent severe violence, and it's associated with a 750% increased risk of homicide. So it's very, very dangerous, and it's very much a predictor of future harm and even death. Since victims of intimate partner violence rarely volunteer that they have been strangled and may often present with little or no physical clinical signs of strangulation or other physical abuse, the American Medical Association, along with several other professional agencies, have recommended routine screening for intimate partner violence. When we first started this, the common thing was to ask the patient, do you feel safe at home? We know now that that is really an unreliable and outdated question, and we should not use that question. A better way to approach it is to ask, has anyone hit, kicked, slapped, punched, or otherwise physically harmed you in the last year? And then also, have you been coerced or forced to have sex that you didn't want to have in the last year? Those are very detailed questions, and it's going to give you a more direct answer. Unfortunately, strangulation victims are consistently underevaluated in emergency departments. Because there's a lack of visible injury, often it correlates with a lack of thorough evaluation. There's still this theory out there. People believe that if there's no visible signs, then there's no harm. Patients are often frequently dismissed as being hysterical, emotionally labile, intoxicated, or that they're exaggerating the details of the assault. Um, so they'll write off their symptoms that they do have as them being dramatic, rather than seeing them as the symptoms that they really are. So the moral of the story is always ask patients that are that you're seeing with symptoms, ask them about intimate partner violence, and always ask them, assess them for strangulation and that screen positive for IPV. Always ask them about strangulation and always assess them for strangulation, because they often won't tell you, or they'll tell you they've been choked. They're not going to say they've been strangled. So always assess for that. When working with victims of intimate partner violence, be receptive. Don't appear shocked. Just put on your poker face. Don't act like, oh my God, that's the worst thing I've ever heard, or oh my God, I don't believe you. Just be very direct and talk with them and listen to what they have to say, and don't act like it's anything out of the ordinary. Approach this from a global standpoint. You want to normalize intimate partner violence. Say something along the lines of, I ask all my patients these questions because intimate partner violence is so common, and I want to make sure that I'm asking the right questions and I'm able to help the people that need to be helped. Also, listening. Being listened to can be an empowering experience for a patient who has been abused. So use your listening skills and be there for them and let them know that you are hearing them and that you believe them and you're listening to them. Communicating belief. Say something along the lines of, that must have been very frightening for you. That lets them know that you heard them and that you are listening to them and that you believe what they're telling you and that you're with them, that you're not just ignoring them. Validating their decision to disclose. Again, something along the lines of, it must have been very difficult for you to talk about this. I'm glad you were able to tell me this today. Acknowledging how difficult this decision was and validating that for them and letting them know that they made the right decision to disclose that to you and that you're there and you're listening and that you want to help them, that you're there to help them. Emphasizing the unacceptability of violence. Just telling them you don't deserve to be treated this way and letting them know that it's not, the violence is not right, that they didn't do anything to earn that, they didn't deserve that, and to let them know that the violence is not the right answer and is not okay. We want to be aware that of some of the following signs and symptoms that could be related to intimate partner violence. And this is by no means an exhaustive list, but looking for bruising in various stages of healing, ruptured eardrums from getting hit upside the head, delay in seeking medical care, history that doesn't match the physical findings, or a stress-related illness, anxiety, panic attacks, drug or alcohol abuse, just trying to cope with the daily trauma that they're going through, chronic headaches, joint pain, muscle pain, sleeping and eating disorders, suicide attempts or other psychiatric illnesses, and gynecological problems. So all of those things could be symptoms of intimate partner violence. So look at those things when you're evaluating your patients. So now we're going to move into performing the actual physical examination. So the physical exam is going to consist of getting a medical history, a forensic history of the event and what happened, a thorough head-to-toe physical examination, a neck exam, any photography of any injuries, and a neurological exam. So for the medical history, we want to look at any medical conditions, any past or current medical conditions that they might have that could be a sign of physical abuse. Use of any legal or illegal substances, their surgical history, or any hospitalizations they might have had. That, again, we're looking at things that might have been caused by intimate partner violence. Want to look at their history or immunization status. Make sure that they're up to date on their hepatitis and their tetanus status. Are they on birth control, and do they have any concerns about that? And then we want to go on to the forensic history to get the narrative of the actual event. You want to make sure you describe the patient's appearance, their behavior, do they make eye contact, what's their affect, their demeanor. Make sure that you ask about sexual assault. It's very common that women who are being abused physically, they're also being abused sexually. So ask about that. That's very, very important. When you're documenting the forensic history, make sure that any of the patient's statements are in quotes. if it's a direct quote from what the patient says. And then you can ask clarifying open-ended questions. So, when they say he did this, who is he? What do you mean by he hurts you? Um, you know, when I see injuries like this, I'm concerned that someone might have hurt you. Things like that to help them maybe move on and explain things a little further or go into more detail about what they're saying. Some more direct questions that you might ask are you concerned about the safety of yourself or your children? Are there ever any times when you're frightened of your partner? Does the way your partner treats you ever make you feel depressed or unhappy? I think there might be a link between the illness that you have and your partner, the way your partner treats you. What do you think about that? So those are some more direct questions that are going to require them to answer you a little bit more directly. And then you want to perform a thorough head-to-toe physical examination. And this is going to use all of your nursing skills: inspection, auscultation, palpation, photographs of any injuries that you find, and collection of evidence if necessary. When you're assessing for signs of injury, I like this BALB step acronym. B is for bruising, bleeding, bites, and burns. A is for abrasions and avulsions. L for lacerations. D for deformities. We're looking for acute deformities. S for swelling or stains. T for tenderness or trace evidence. E for erythema or redness. And P for petechiae, patterned or penetrating injuries. And if the patient has reported that they were sexually assaulted, then you're going to want to do a detailed genital exam. Just like with your sexual assault exams, you're going to do a visual inspection using separation and traction, do your speculum exam looking at the vagina and cervix, collect any evidence that you would need in that situation, evaluating for signs of trauma, and remembering, of course, that it's normal to be normal, and just because they did not have any injury does not mean that they were not sexually assaulted. Another important step is the neck exam. You want to evaluate the 6 axes of movement. So you're looking for a range of motion. So you want to evaluate for flexion, have them move their head up and down, forward and backwards. Extension, so move their head to the left and the right. And then side turning, bilateral, have them put their ear to their shoulder on each side. So looking for that range of motion, and if they have any pain or discomfort in any of those movements. We talked a little bit about photography. For our forensic photography, we can use digital camera for body surface injuries, and then of course the colposcopy if the patient was sexually assaulted and we want to look at those tissues in the vaginal area and the cervix and vagina. A really good practice to start out with is, before you even start anything, is to do this overlapping photographic storyboard. And you're just going to start at the head of the patient when they're still dressed, and you're going to take photos in sequence. You can see like the head up to about the shoulders, and then getting it from the shoulders down to about the belly button, and then from about the belly button down to about mid-thigh. And that you can put those, then you can take those photos and you can kind of piece them together and get a total picture of what the patient looked like when you first saw them. And these are just a little bit more detailed, closer photos than one solid picture from a distance to get the whole body into one photo. Each injury or lesion and each scar should be photographed from 3 different distances. You always want to start with a long-range photo that's going to show the injured portion of the body in relation to the rest of the body, so that you know what you're looking at. So you can see the upper left-hand corner. You can see that in that photo I have both feet, so you can tell that the injury is on the right foot. And then you want to get a medium range photo that's going to capture the injury and surrounding anatomical markers like joints and appendages. And you can see the injury a little bit clearer. And then lastly, you want to get that's going to show the size of the injury and the location on the body. So it's going to give you a little bit closer photo and a little bit more detail on showing you where it's at and what it looks like. And then lastly, you want to get a close range photo. This focuses directly on the scar or lesion itself, and it must show the color and shape of the injury. And if there's several small injuries adjacent to one another, you don't have to take a photo of each of these separately. You want to have a standard marker in there, and so I use the AFBO standard measure in there, so that, and you want to make sure that you have some distance between the actual injury and your standard marker, so that you're not covering up any part of the injury. So just like the television program will show the viewer the outside of a building to establish where the characters are going, the crime scene photographer should capture the whole scene first, using the wide angle shots covering the entire scene from the approach and through every area. Close-up images of evidence can be taken out of context, so establishing the scene first with wide and medium shots is critical. If the patient was sexually assaulted, you're going to want to use this colposcope. This is the colposcope that we use in our program. It's very simple to use, and it gets really good photos. You can see a photo on the right-hand side. This was a photo that was taken with one of our colposcopes. It's very clear. It's easy to use. We have a little foot pedal that we can use with it. It keeps our hands free to be able to perform the examination while we're doing the photography. Next, we want to move on to the neurologic exam. This is kind of an easy way to do a neuro exam, and basically we're going to look at different areas. So the first thing we're going to look at is the senses, and this is going to evaluate cranial nerve 1, 2, 8, and 9. You're going to ask the patient if they have if there has been any changes in smell, sight, hearing, or taste. And that one question is going to evaluate those 4 cranial nerves. Next, we're going to evaluate cranial nerves 3, 4, and 6. And with this, we're going to evaluate eye movement. So you want to have them move their eyes in each of these positions, up and to the right, just up in the center, left and up, in the center, mid-range, right, primary, and left, and then down to the right and down, and then to the left and down. And that's going to evaluate all of your eye movements, which is those 3 cranial nerves. And then also you're assessing for movement by up and down, left and right, and then in an X pattern. That's going to evaluate those cranial nerves. Lastly, we're going to do this assessment, which will assess for cranial nerve 5, 7, 10, 11, and 12. And with this one, you're just going to kind of do a series of movements. You're going to lightly touch the face. You're going to have the patient chew or bite down, have them smile, have them stick out their tongue and say ah, and then have them shrug their shoulders against your hands, against pressure. Just a few things that I haven't covered yet. Whether or not to collect swabs. This is going to be something you want to discuss with your multidisciplinary team, and it's going to be indicated based on the history. Obviously, if there's been a sexual assault, you're going to want to collect your routine, sane exam specimens that you would normally collect. If for an actual strangulation, it's going to really depend on the time frame since the assault and whether or not that touch DNA is still going to be valid. So talk to your MDT and make a decision of whether or not there's going to be validity in collecting any specimens. Sometimes, the bulk of the evidence you're going to be collecting is photographs of injuries. If you do collect specimens, it's going to be dependent on the history and patient consent. Some of the major ones you are going to want to collect are, again, this has to do mostly with sexual assault, but anal, vaginal or penile, cervical, fingernail swabs in case they, were able to scratch the victim or something and get some of their DNA under their fingernails, a buccal swab for their DNA, the patient's DNA, And then in strangulation, you want to swab the neck to get that touch DNA, and then any additional swabs that their history would indicate. Neck measurement is a step that may or may not be done. In reality, if you're not going to do a follow-up measurement, then a single neck measurement is really of no value. So if you have the means to have the patient come back and do a second measurement to be able to follow up and see if there's been a change, then you can certainly do that. The other thing is that it's not as simple as you think it is. There's very specific ways to get it done, to have it done consistently and correctly. So a lot of programs are not doing neck measurements. If you do this, you want to measure the neck with a measuring tape to establish a baseline for follow-up measurements. So you want to make sure you're getting that follow-up and you're looking to see if there's any swelling present. So yeah, you can decide if that's something that you want to do based on if you're going to have follow-up or not. Remember that red bruises are common and that they are easy to mistake for erythema. So how do you tell the difference? Very simply, does it blanch or not? If you press on the red area and it blanches, then it's erythema. If it doesn't blanch, then it's ecchymosis. And so you want to make sure that you document in your chart whether or not that area blanched, so that you can testify to that very clearly, that you checked that and how you checked it and determined whether it was erythema or a bruise. When the patient reports tenderness to palpation without visible injury, you want to document that by taking one photo with the examiner's gloved hand pointing to the area of tenderness. The reason for the gloved hand is that it's just more professional looking than having your ungloved hand touching the patient. So that's the recommendation for that. Let's talk a little more about non-fatal strangulation. When obtaining a history of the strangulation event, you want to ask the patient to quantify on a scale of 0 to 10 how much pressure was applied to their neck during the strangulation. Ask them what they thought was going to happen to them. Very commonly, when I ask this question, I thought I was going to die. That was a very common response that I get to that question. Ask them what the assailant was saying to them before, during, and after the strangulation, and what made the strangulation stop. Some of the photos that you want to capture during a strangulation exam is you want to capture a series of mid-distance photos of the front, back, left, and right side of the face and head, the upper chest and neck area, and the upper back and nape area of the shoulders. You want to capture another photo of the front of the neck with the head tilted back to expose the full neck and the area under the chin. If you find any visible injury, then you want to capture a series of close-up photos if they're wherever they are, on the front side, right side, left side, or the back of the neck, with and without their standard measurement. This slide is only showing two views, but I still recommend that you do the 3 views, because if you look at some of these, it's really hard to tell just by looking at it, is that the right side of the neck or the left side of the neck? What exactly am I looking at? So I think it's still really good practice to do the 3 views, to have to be able to see, yeah, I'm looking at the left side of the neck or the right side of the neck. I think that that's really helpful. But you want to conduct an assessment for other visible injuries in other areas, such as the ears, behind the ears, the scalp, the jawline, the submandibular area, and the chin. So those are all areas you want to be sure that you're assessing for signs of any injury. Again, we already talked about a little bit about the eye movements. And you could even do this, when you're doing the eye movements for the cranial nerves. But the reason that we're looking at these now is that we're wanting to look for any petechial hemorrhages or subconjunctival hemorrhages. So you're actually looking more, not so much at the movement, as you're looking to see if there's any injuries in the eye, in the white part of the eye. So you're going to have them go through these motions again and looking for actual injury and photographing that. Also, when you're evaluating the eyes, you want to capture a series of close-up photos of each eye using the eye inversion technique. You're going to apply pressure medially and laterally on the lower lids with a cotton tip swab behind it, and that's going to invert that lid so that you can look beneath the lid. You can use those same eye movements that we used before to inspect the upper and lower eyelids, so you can be looking for petechiae, hemorrhaging, and any other injury that you might see. You might want to get a close-up photo of the upper and lower lips. If you see or suspect bruising, hemorrhaging, or detect any other area of interest on either the upper, lower, or both lips, then you want to capture photos with a measurement scale for documentation. You also want to get a series of close-up photos of the oral cavity. This will help you to assess the soft palate, the uvula, and oral pharynx. If you see bruising, hemorrhaging, or detect any other areas of interest, capture additional photos of the finding. These are sometimes really hard to get good photos of because of, our cameras. A lot of times we have them in the autofocus mode, and it doesn't really know what to focus on in this kind of photo. So you pretty much want to use manual focus on these. Make sure you've got a good light source. These are sometimes difficult photos to get. You want to get photos of the front and back of both hands separately. If you see any bruising or any other area of interest, then you want to get additional photos with the measurement scale and without. And then you want to get close-up photos of the fingertips and fingernails from both hands. Again, get measurements with and without a scale if you see any injuries. When asking the victim to describe the strangulation itself, we want to be very victim focused and not re-traumatize our patients. So one of the things that I do is I have this document that I use, and I show this to the patient, and I ask them to point to what looks like how their strangulation occurred. You never want to have a patient demonstrate on themselves or on another living person what the strangulation looked like. That's very re-traumatizing. Another thing that I also do, especially if what the strangulation looked like is not on any of these 8 pictures, then I have a wig head that I use, and I will hand them the wig head and ask them to show me with the wig head what the strangulation looked like. And I take a photo of them showing me on the wig head what the strangulation looked like. That's just how I do it. I just think that I have a record of it that way, so that's what I do. So let's move on to the signs and symptoms of strangulation. Things that you want to assess for. This is, again, a pretty long list of things, but you definitely want to ask about voice changes, any trouble swallowing, any difficulty breathing, any visible injuries on the neck or the chin or the mastoid, any petechiae, subconjunctival hemorrhages, loss of bowel or bladder control. That's a really important one. And patients a lot of times are really embarrassed about that, and so they don't a lot of times like to answer that. So I usually tell them, please don't be embarrassed about this. This is a very common finding in strangulation, and so I just need to make sure whether or not you had lost any control of your bowels or bladder during this situation. Any loss of consciousness, ask them if they have any memory loss during that time. Looking again at your neuro findings, and then did you have any swelling of the neck, any lung injuries, any pain, swelling, bruising, any contusions, abrasions, any of those injuries that we want to be sure and look for. Petechiae are burst capillaries that occur above the area of pressure. So wherever the strangulation occurred, you're going to see that petechiae above that area, and it's caused by obstruction of the jugular vein, and so the blood can't come back down from that brain in the head, and so it gets clogged up in there, and it causes those little capillaries to burst. They're pinpoint round spots. They can appear red, brown, or purple. They're usually really tiny, measuring less than 1/8 of an inch, and they can be found under and on the eyelids, around the eyes, on the face, the scalp, the hard palate or soft palate, the neck, also on the inside the lip, in the hairline, behind the ears. So they can pretty much be anywhere above that area of pressure. These are just some more pictures of petechiae places that you can see them here on the inside on the eyeball, inside the eyelid, behind the ear. So just some more areas that you can see petechiae. Petechiae do not prove strangulation, and their absence does not disprove it. They are simply a marker of increased pressure in the blood vessels above the strangulation site. But the finding can be consistent with the patient's report of strangulation. That's the fact that their veins have been obstructed. So it is an important finding. You need to be sure that you're documenting this, but it doesn't, the presence of petechiae does not mean that the patient was strangled. There's lots of things that can cause petechiae that aren't strangulation. I did labor and delivery nursing for a long time, 30 years, and I saw my share of petechiae on patients after they pushed for a really long time. So there's lots of things that can cause it that aren't strangulation. But like I said, it can be certainly consistent with the patient's history that they're providing you. You might see self-inflicted abrasions, particularly if there's a ligature. The patient is going to fight and they're going to try and get that off, and so they're going to put their hands there and try to pull that off, and they might scratch themselves and cause that self-inflicted injury as they're trying to remove that ligature from their neck. Subconjunctival hemorrhages or broken blood vessels in the eyes. This indicates occlusion of the jugular veins. So that's a common finding that you might see. Erythema or redness from pressure. You might be able to see this at the location of the pressure from the strangulation event, but often this isn't visible until 24 hours after the event. It may be visible with an alternate light source. Ligature marks, if they use a cord or other object in the strangulation event, then it's likely that you're going to see some kind of bruising or erythema or mark on the neck from that object that was used. Remember that anything can be used as a ligature, so a necklace, a belt, a scarf, article of clothing, a telephone cord, anything that you can find pretty much can be used as a ligature. So treatment and referral. What do we do about all of this now? This is the recommendations for medical radiographic evaluation of acute adult non-fatal strangulation. You can find this on the Training Institute for Strangulation Prevention website, and it's kind of a decision tree about when the patient presents with a history of loss of consciousness, visual changes, ligature marks or neck contusions, incontinence, neurologic signs, any of those things, then you want to be sure that you're giving them a 325 milligram aspirin, and if there's any delay in the radiographic study, and then you want to get a CTA of the carotid vertebral arteries. That's the gold standard for evaluation. If you can't get that, you can do just a plain CT, but the most accurate thing you can do is get a CTA. So that's our recommendation for that. And then the other side, the right side of the decision tree, is that they don't have loss of consciousness, or they don't have any visual changes or any petechial hemorrhages. If they don't have any of those external signs, then you can discharge them home with detailed instructions, including a lethality assessment and instructions to return to the emergency department if they have any neurologic symptoms, any dyspnea, dysphonia, odynophagia, that's a hard word to say, or if that develops or it worsens. So just kind of a decision tree to let you know how to deal with these patients and what to do if they present to your emergency department. This is just another kind of view of those recommendations. And one of the things that I did was I created some little like business card size laminated cards, and I hand them out to my law enforcement officers, EMS providers, and it says basically this on here, you know, if the patient presents with any of these signs, that they need to have a CTA done, they need to be transported to the hospital. And on the other side of the card, it has all the signs, a lot of signs and symptoms that they need to be looking for. And so it's really a nice little reminder. They can carry it in their pocket, in their uniform, so that they have an easy reference tool that if they are on a strangulation call, that they can look at it really quick to just refresh their memory. This is the strangulation assessment card that I was just talking about, that I have put on a little business card and have it laminated that I give out. Thank you for joining this webinar today. I hope that you found it to be useful and informative. If you would please take a moment to complete the survey by following the link on the attached QR code, it would be greatly appreciated. That concludes our webinar for today. I hope you enjoyed it and got something out of it. And feel free to contact me if you have any questions. And I hope you have a great day. Thank you.